Another interesting scenario. So this patient is again a female, 27-year-old this time, with a medical history of hypertension, dyslipidemia, diabetes mellitus, and a surgical replacement of her aortic valve 20 years ago with a Perimount 21 valve. And she also has a known coronary artery disease with non-STEMI and angioplasty with a drug-eluting balloon almost 1 year ago to the LCX. Now the patient has severe bioprosthetic aortic valve dysfunction, symptomatic, with NIHA class 3 to 4 and recurrent hospitalization for acute pulmonary edema while taking a big dose of diuretics. You can see the transthoracic echocardiogram images. The patient has some paravalvular, maybe paravalvular regurgitation, and she also has a mean gradient of 30 millimeters of mercury and moderate regurgitation. So we have a moderate stenosis and regurgitation. She also has a moderate mitral regurgitation. And you see the valve, it's really calcified, and also a moderate tricuspid regurgitation with signs of moderate to severe pulmonary hypertension. And now we're going on to the screening coronary angiography of the patient. You see that the RCA and the LED are okay without stenosis, but we have a severe stenosis in the distal part of the LCA, which was treated ad hoc with placement of stent 2.5 to 15 millimeters, and that's the final angiographic result. So based on her age, the patient was directly assessed for TAVR. And you can see here the CT screening. The patient have adequate high origin of coronary vessels and a safe VTC of about 6 millimeters for both RCA and LC. You see that we have some calcium in the valves, the cusps of the bioprosthetic valve, especially in the right cusp. And as for the femoral access, we have adequate diameters for the valve deployment. So based on the valve-in-valve application, the patient have a 21 perimount valve, which means that the true ID of the valve is 19. But as we can see, this valve is not fracturable, but it is expandable if we use a larger non-compliant balloon. The application informs us that based on this size, we can use one of these valves here. So now we have to decide the patient's main characteristics that we took into account in order to decide the right valve for this patient was the fact that she had a really small surgical bioprosthetic. So we need to maximize the effective orifice area as far as we can, and that the patient has known coronary disease, so we need to preserve the potential of future coronary access. So we decided to use an Allegra valve, which has the advantages of a self-expandable supraannular valve, which means that it can maximize the effective orifice area. And it also has a unique stent shape, which is shorter than the other self-expandable valve. And it also has keeps some distance from the ascending aorta, which means that we can easier have access to the coronaries. It has also good hemodynamic result, especially in small native annuli and small surgical valve. So choosing this Allegra, the application tell us that the ideal placement of this valve, it's 3 to 5 millimeters below the fluoroscopic marker in the C ring. So we're going on to the procedure. This time the procedure was done under general anesthesia because the patient had a COPD and we couldn't keep her in light sedation. And we choose the right femoral artery as our main access for the valve deployment. And we also punctured the right radial artery in order to have angiographic guidance. So now I will go on directly to the valve crossing because this was really difficult, as you're going to see. Where we start with an AL1, AL2, a straight and hydrophilic wire, and nothing. So then we tried to use a mother and child technique using an AL1 7 French catheter and into this multi-purpose catheter. And we tried to close the valve. And you see that with this technique and after several efforts, we tried to cross. But it was difficult to advance even the catheter, the multi-purpose catheter. And we were starting to think if this is because we have passed through a paravalvular leak. But we inserted the stiff wire. We have chosen an Landerquist wire. And we pull out the multi-purpose and the AL. And now we try to cross a pigtail catheter. But you see, it's really difficult.
If this was a Landerquist, why'd you go with the pigtail?
We wanted to make an injection to see if we are in the correct place. And
well, we were not actually sure that we were
in the right,
because there's a paravalvular leak. Sometimes you might cross, and so before placing a balloon, we try to investigate further.
Echo could not help you there?
This is the next step.
Yeah.
Sorry. See, we're in place. We use the echo and transesophageal echo to see if we are in the right. We have made entrance valvular crossing. Here we put a pacemaker because the patient had bradycardia. We see that probably the wire is in the correct position, meaning transvalvular. So we tried to advance the balloon of the valve and Osipka 18 French balloon, but we couldn't, as you can see.
Did you change the projection, the fluoro projection?
Yes, we changed a lot of time the projection in order to try to get in and understand where we are, but nothing. So we cross again, one more time. You see, it's really difficult every time.
So we're in the same position, the same crossing?
Probably we're at the same position and we cannot pass. Now, we put again.
No.
Now, in the next few minutes, I'll show you that we will try to advance a smaller balloon. We
have a Landerquist
check
now in
again.
the LV.
For the time being, we have a Landerquist in the LV. Yes, yes. We check again one more time that we are in the correct position and not through the paravalvular leak. You see the wire seems to be in the center of the valve, so we strongly believe that we are okay, and try to put now a smaller Mustang 12 to 14 millimeters balloon. But again, we have a lot of difficulty. We can't cross the valve with the balloon.
Wow.
So we think that it would be a good idea to change the wire to see if it can help. So we try to put a pigtail to change in order to change the wire and to use a safari wire. But even now, the pigtail cannot cross the valve.
I hope you don't lose it again.
We lost it again, one more time, but we tried again. We didn't stop. We crossed again, yes. The same difficulty every time we try to cross a catheter. So now we change the wire and we try with the Safari small wire. And now you will see that the Mustang small balloon crossed the valve.
Goes, yeah. Well, the Landerquist biases you more to the outer curve because of the stiffness. So.
Yes, probably. So now we make a dilation with difficulty, but you see that we dilate the valve.
Very good. Full expansion.
So now we advance the Osipka 18th balloon for the valve. We advanced it with a lot of difficulty.
That went in.
And we dilated, you see this waist.
Wow.
But we have a good sealing, meaning we have made a good dilatation.
Very good.
So now we're ready to cross the valve. We position the valve in the right place, meaning we need to have 3 dots in the right part and 3 in the left part, because this is the appropriate orientation. And we try to cross the valve. And you see again, we have a lot of difficulty. In fact, we cannot advance the valve.
Sure.
We made a lot of efforts. We thought we have dilated enough our valve in order to pass, but we can't. So we think the problem is the wire, and we need a more stiff wire and Landerquist wire.
This would be
to
a
pass.
body wire case.
This is
for
what?
For the body wire, for a second wire.
Yeah.
To place a second wire so we can
Yes.
have more backup.
That would be the other option.
We thought of changing the wire and put the Landerquist, but in our effort to put out the valve, we lost the wire again, one more time. As you will see, we try not to lose it, but it had stuck, so it went out.
Wow.
So we didn't stop, we crossed again.
At least we have a good opening at that time, and we are going easily inside.
Yes, it was easier and easier every time. And but again, you see that despite all these dilatations, the catheter cannot cross easily the valve. But we are in, and we insert the Landerquist wire again, the more stiff wire. And we thought it was a good idea to dilate again and better our valve with a non-compliant Atlas balloon of the same dimension, 18 balloon, which crossed the valve. So we did the dilation with the Atlas balloon.
Yeah. Very good.
We see we have a good dilatation.
In general, you see the apex of the heart in these rough cases better in the RAO projection. Okay. So you get a better idea where your wire is.
And now we cross figures and we
the second balloon also. So this is not what we normally see.
This is super high.
This time and after dilatation and with the lander twist wire in, we managed to advance the valve.
Which is now, what size is this valve? We forgot all about the valve.
Is 23 Allegra valve. A 23 Allegra valve. So you see,
we're focused into the
in our effort to cross the valve. So we need this dark marker to be not to overpass these markers.
Well, with the inflation, we saw where the stenosis level is at least, so we have a good idea.
Yes.
If we end up just a little bit lower from the current frame, that's good.
Yes, now we try to fix with the wire and the implant depth. We start here at the bottom of the sewing ring.
Okay.
And we slowly open the valve.
All right.
So we think that we are in a good position and we open the valve. Now the valve is open. We are happy with the implantation depth.
Seems you need to post that later.
Yes. And now we put out the valve and we will make
What's the wire?
The wire again went out.
The wire?
What?
Watch the wire.
Yes. Oh, no, the wire again went out. We couldn't keep it inside. But we make an inflation and we see some regurgitation. But we measured the gradient and you will see that we have a zero gradient. And we have a good aortic diastolic pressure. So we think we're okay with the result. We took out the sheath and we tightened the shutter. We make a last echographic check. We see that we don't have a large paravalvular leak.
No.
You can see here. And we have a max velocity of about 1.8 and a mean gradient of 7 millimeters of mercury. So we were really happy with the result. The patient were okay after the procedure. The fourth post-TAVR day, the echogram saw a PR prolongation and she had a pause 1.5 seconds in the monitor, but we decided just monitor the patient and she was okay after this, and he stayed in the hospital for a total of 8 days. And she left with these echo images before discharge. You see that we have a good valve without a large regurgitation and a good hemodynamic result with a max velocity of 1.8 meters per second. Thank you.
I think, Yannis, that with this scenario, actually what you did, you added the information of revascularization and the benefits of the vascularization of the lateral wall and the respective papillary muscle. So this scenario, you had two pathophysiologies. the moderate stenosis and the regurgitation of the valve, as well as functional component of the mitral regurgitation. That was the reason that the pulmonic pressure was that high, George. So actually, in this scenario, you have to revascularize. It's something which is missing from our clinical perspective.
Yeah.
I mean, I would be considered, after all this work you did, to do the post-dilation anyhow, just because of the symmetry of the valve, not
But
because of
we were so
hemodynamics. But I think
extensively
after
doing
6 times recrossing, you were
pre-dilatation.
tired. You were tired of recrossing. But I trust you would be able to still do it because you crossed so many times successfully.
But we had 1.8 meters, so it's a 7-minute gradient.
We had a
So
good
we
diastolic
aggressively
pressure.
predilate, post-dilate, predilate with a non-compliant balloon as well. And this valve has a unique hemodynamic future, so it's very hemodynamically accommodating, especially in this small annuli. So we wanted also to avoid any possible embolization, which is not infrequent in this patient. So in this situation, I think we had a good indication. Small annuli, you need to have the most accommodating frame in this regard.
Great. I mean, valve choice is the right valve choice, no question. We have a question from the...
Yeah, no, that's what I was going to say. I mean, you're lucky that you had a self-expanding. What if you had an S3? So you lose the valve, you lose the wire, you have the S3 in there, you have the introducer. Yeah, so you have to take it out, I guess, right?
Yeah.
Yes.
I mean, there's no other
No.
option, right? So you're lucky you had the Allegra.
Well,
Not the
sometimes
Allegra
you
valve
can-
at all, but you're lucky you
sometimes
had
you can
not
get
a
it out.
sheathless.
Sometimes you can get it out, but most of the time you can't. Yeah, great. All right, let's move on to the